Hi guys, Dr. Gillard here. It is the last lecture for CVPP. Everybody's so excited. And this is our one pulmonary pathology lecture. Didn't always run out of time, but I have a lot more of these pulmonary lectures up on my YouTube channel. You should watch those for boards. It's spring 2021. It's Thursday. It's week 10. Off we go. Now, to save time, I used to go over anatomy for a whole lecture. I don't do that anymore, so you're on your own. I assume you know the anatomy, and I strongly recommend you to go to this link or Google Dr. Gillard Anatomy Histology Review of the Respiratory System, and it'll pop up if you search that on YouTube. And watch that. You'll get more out of the lecture that way. All right, the star of the show today is COPD, chronic obstructive pulmonary disease. But that's actually a member of a bigger category called obstructive lung disease, or OLD, or old, because it happens with older people. No, it happens with younger people too. So OLD is a umbrella term that has many different categories underneath. But they all have one thing in common. That means that something is blocking the flow of air through the tracheobronchial tree to a point that the patient becomes hypoxic and starts, it can kill people, and it does kill people. Yep, so those affected typically suffer a progressive breathing problem, and that's true. And it could reach a point where they develop hypoxia, and you know the rest of the story to that. There's always a confusion over obstructive lung disease. There's another major category of restrictive pulmonary diseases, which are a different animal, and I don't have time to go into all of them, but just to show you there's a difference between them. They're not AKAs for each other. Restrictive pulmonary disease occurs when something reduces the ability of the lung to expand. Either the elastic tissue of the lung is wrecked, so when you take a breath in, your lung doesn't expand, and if it doesn't expand, you can't suck air in. Or it could be something physically compressing the lung. Maybe a big tumor in the lung is pushing into, or a big tumor in the chest wall or in the pleural cavity, or a big hemothorax or pneumothorax. Something is squishing the lung tissue so bad that it can't expand. Or maybe you have horrible scoliosis and one of the lungs just can't expand when you breathe in. So these are potentially curable diseases, where obstructive lung diseases, there's no cure for them. That's potentially curable, the restrictive pulmonary diseases. Diaphragmatic excursion tests would be greatly decreased on these restrictive pulmonary diseases. Some examples: severe scoliosis, severe obesity, where you have a lot of fat in your thoracic cavity, it's squishing the lungs. Anything that squishes the lungs from the outside or wrecks the lung tissue. Poliomyelitis, we won't get into the mechanism, but that messes up the lung's ability to expand. Pulmonary fibrosis, pneumoconiosis, asbestosis, sarcoidosis. Those are two common ones that cause RPD. Now let's turn our attention back to obstructive lung disease. It is the second most common cause of permanent disability, not death, but permanent disability in the United States, only behind heart disease. So this is a huge problem. The world prevalence of treatable obstructive lung disease is 16%. That's a huge problem. The mortality rate has been worsening. We're not sure if it's environmental factors, or we're not sure what the story is behind there. And categorizing the different obstructive lung diseases is challenging because there's overlap between the conditions. So this is guaranteed a test question, right? These are so easy for me to make a question, and so easy for boards to ask. So you got to know this slide. Make a note card. Who are the obstructive lung disease subcategories? Well, COPD, chronic obstructive pulmonary disease, emphysema, and COPD, as we'll learn in a bit, is a combination of emphysema and bronchitis. You very rarely have one without the other. And some authors are more and more including chronic asthma in there because it can present quite similarly. But we'll keep chronic asthma as a separate condition right now. Bronchiectasis, chronic tracheal obstruction from a tumor, or you're born with a stenotic tumor or stenotic trachea. And chronic bronchial obstruction, you're born with a small primary bronchi, say, or lobular bronchi, or something like that. One thing in common, we already said all the OLDs have airway obstruction. The cause of this obstruction, kind of like a beaver dam, right? If you have an obstruction of the pipe, it's a beaver dam. The causes of these obstructions can be broken down into three categories. A problem inside the lumen, a problem in the wall, and a problem outside the wall. So let's look at these. So we'll get more specific into these, but here is a cross-section of let's say it's a respiratory bronchiole. Remember what a respiratory bronchiole is? No, let's change that. Let's say it's a terminal bronchiole, because this one's got a lot of smooth muscle in it. Terminal bronchioles have lots of smooth muscle. Remember, that's the last member of the conducting airway system. And so this is an asthmatic maybe, or someone with chronic bronchitis. They have tons of mucus clogging, beaver damming the tube, the lumen of the bronchus. And you can't get, it's like beaver dam. You can't, instead of blood getting in and out, you can't get air in and out. You could have a problem in the wall where you have a hypertrophic mucus gland, or submucosal glands they're called. And it's gotten from, asthmatics have this problem. The gland gets big from exercising, from having asthma attacks, and it starts to narrow the size of the lumen because the gland is taking up more space. And then you can have problems on the outside. So a common one too is to have a tumor growing outside lung cancer, and lung cancer now has reshaped this bronchus into a much smaller specimen. Then there's the concept of radial traction loss. We'll get into that. That's an important concept. People with emphysema have a problem with radial traction loss. We'll get to that. So interluminal obstruction, causes of interluminal beaver dams, excessive mucus secretion. Mucus is overproduced in people who have chronic bronchitis, who have chronic asthma, and cystic fibrosis. What else can obstruct the lumen? Well, blood can. If you have pulmonary edema from a failed left heart, if you have high pressure heading back toward the heart, it raises the microcirculation pressure around the alveoli, and the blood spills into the alveoli. Right? There's a little interstitium there, but there's no tissue to swell. It just dumps right into the alveoli, and you get pulmonary edema, and that can back all the way up into at least the terminal bronchioles and cause a beaver dam. What could cause this pulmonary edema? Left heart failure, left valvular disease. We've talked about this already. Mitral stenosis, aortic stenosis, even regurgitations can cause pulmonary edema. Any beaver dam, that would be downstream, because the blood is flowing from the lungs to the left heart. So any beaver dam downstream can increase the pressure, just like the water backs up from where the beaver dam is. And like here's the heart would be up here. Let's say the patient has a failing heart or stenosis. Any beaver dam, maybe even a tumor in the left atrium, any type of beaver dam increases the pressure in all these pulmonary veins and all the pulmonary microcirculation. And if there's too much pressure in these capillaries, they leak blood. And where do they leak blood into? There's no skin, or there's no subcutaneous tissue to leak into. They connect right to an alveoli, which is hollow. And so the alveoli can become filled up with blood. And that's basically the story. You have hemoptysis with this condition. You cough up blood. Another possible interluminal obstruction. So here's a child who aspirated some metal part. It was like kind of jelly bean shaped. You can tell it's a child. Look at the bone growth is not complete yet. And so that looks like it's stuck in the right main stem bronchus, which is where they usually get stuck, and that's a beaver dam. And yeah, so that's a cause of interluminal obstruction as well. Could be a tumor though. You could have a tumor growing in there. That would not be internal wall. That's intraluminar obstruction, luminal obstruction example. Intrawall obstruction means there's something in the muscular part of the tube that is either growing, or maybe it's the muscle itself. And in fact, that's one of the most common cause. Patient with asthmatics, that muscle goes into a spasm and it beaver dams off the terminal bronchioles. And if that keeps happening over and over and over, the muscle's like working out. It's going to get big and muscle bound. And yeah, and it'll slowly decrease the natural size of the lumen. So that is definitely possible. That's usually seen in people with chronic asthma who have those spasms. That's the only disease I know of that can cause spasms of the smooth muscle of the bronchioles. We talked about this already. So a mucous gland that lives, or submucosal glands I believe they're called, that lives in the wall of the bronchi, the tracheobronchial tree, they can hypertrophy in patients with especially chronic bronchitis. Chronic asthma causes oversecretion of mucus. But if you're exercising those glands all the time, just like lifting weights, they're going to get bigger and bigger and bigger. As they get bigger and bigger and bigger, they start to decrease the lumen. Chronic inflammation of the airways, yeah, if you get, just like the esophagus, chronic GERD, right? What does that do to the esophagus? It can start to not only shrink it, cause a diaphragmatic hernia, but it can also scar it up to the point where the lumen gets narrow because of all the scar tissue. And the same thing here. Conditions like asthma and chronic bronchitis, where you have, especially chronic bronchitis, where you have chronic inflammatory disease of the airway walls, I mean, you can get a scar tissue from that, and that can beaver dam it. Peribronchial obstruction, so that means it's not actually inside the tracheal or the tubes, it's on the outside of the tubes. And so we could have something physically compressing the airway, like a tumor or blood in the lung, especially in the pleural cavity, an infection growing, a big infection party where maybe you're getting an abscess, lymph node enlargement pushing into the lung, anything that pushes into the lung from the outside. But there's also the concept of radial traction is considered a peribronchial obstruction. And we'll talk about this in a minute, but in the, for example, the terminal bronchioles, they have no cartilage. Your trachea, your primary bronchus, your lobular bronchi, they have a lot of cartilage to help them stay open. Remember, when you take a breath in, what happens to the pressure inside the tracheobronchial tree, all of the tubes? It gets negative, and the tube will suck in unless something's holding it open. Well, most bronchioles have a lot of, this is a cartilage layer here, that resists that being sucked in. But that's not true of the terminal bronchioles. So luckily, the parenchyma of the lung actually connects right in to the outer wall of these terminal bronchioles. And because the lung, remember from anatomy, the lung is like a sponge, right? If you squeeze it, it pops right back out. So it literally holds, the lung tissue holds these tubes open, and that's called radial traction. So if you get a disease, that snaps these or wrecks the parenchyma of the lungs, like emphysema, you lose radial traction, and these can collapse, and you're in big trouble then. All right. So here's a patient who comes in. So you take an X-ray. They're having trouble breathing, and you find these things. What are these? Those are called chordomas. And they are compressing so many of the bronchial tubes, that the patient can't breathe. They're all collapsed. They're squished in, so the patient's having trouble breathing. Now this is fixable. You can remove those. And yeah. Loss of radial traction, I just talked about that, so I don't need to say that again, but you can read about it. And everything I just said already, and yeah, radial traction holds those small airways open, especially the respiratory or the terminal bronchioles. Not the respiratory bronchioles, the terminal bronchioles. If I said respiratory bronchioles, that's a mistake. It's terminal bronchioles. That's the last part of the conducting airway. Respiratory bronchioles are part of the asinus, part of the respiratory unit where gas exchange occurs. They don't need to be really held open. Yep, everything we said. So I sorry, explained all that. All right, let's get into the weeds a little deeper in COPD. So again, it's a category of obstructive lung disease. It's also an umbrella term, even though it's under obstructive lung disease. Underneath it are emphysema and chronic bronchitis, or you can have a mix of those. And as I said, more and more students or more and more authors are including asthma, chronic asthma, not run-of-the-mill garden asthma, but chronic asthma where the patient's on weekly medication for it. They include that in there as well. These conditions are irreversible. There is no fix. Chiropractic does not fix these. I had to save slides. This was like 100 slides, so I took out the big chiropractic section. But there's meta-analysis. It's done by chiropractic organizations, and there is no treatment does not work. You can't. I mean, you could try anything, but there's no proof that it works. But the point of those papers was to say, for heaven forbid, don't recommend that patients stop taking their medication for these diseases in place of, and just replace it with chiropractic care. That's irresponsible, and that's going to get you sued. All right. Yeah, both irreversible conditions. Classic signs and symptoms of COPD. Well, if part of the lung is wiped out by something, you can't breathe. So you have shortness of breath, which is dyspnea, especially dyspnea on exertion. You try to go up the stairs and you don't have enough lung tissue that is pumping oxygen into the blood. So you run out of oxygen and you're breathing. You might have to sit down. You might have to lay down if it gets bad enough. Chronic cough. Chronic cough is more common in chronic bronchitis compared to emphysema, as we'll see. When you think chronic productive cough, foul-smelling sputum coming up, think chronic bronchitis. Emphysema doesn't, you can still have a chronic cough, but it's not productive, and it's usually not that big of a problem. Chronic bronchitis, well, I guess, I mean, you can have chronic emphysema, but chronic bronchitis, C is for coughers. They cough like crazy. Exercise intolerance is just like dyspnea on exertion. I mean, you can't tolerate walking up the stairs. You can't tolerate going for a run. Anything that demands more oxygen, the lungs can't provide it. It's not the blood's fault this time. It's not the heart's fault. This time it's the lungs' fault because they just can't exchange enough carbon dioxide for oxygen. What are the image findings? I left this rabbit hole in there. I think this is important. I've talked about this, so it shouldn't be too bad. But atelectasis, specifically something called a reabsorptive atelectasis, which usually occurs from so much mucus that it is produced in chronic bronchitis or chronic asthma, attack of chronic asthma. You can get so much mucus that it completely beaver dams one of the small airways. And if you completely beaver dam it, anything downstream from that, now in blood it would become ischemic, right? If it was a complete beaver dam of a blood vessel, like a coronary artery, anything downstream would die. So it's a little different. If you completely beaver dam one of these small tubes, anything downstream has all the air sucked out of it, and it will no longer exchange air for CO2, so it just collapses. And if that happens over a big section of the lung, the whole lung collapses. So that's called a reabsorptive atelectasis. Other findings are overinflated lungs. Think emphysema, and we'll look at that real quick. So atelectasis is a collapsing of lung tissue. Let's look at the two types. Now we've talked about a pleural effusion, right? Because we know that the chest wall has the parietal pleura around it. I'm making this like ridiculously big, and this can go either way. Let's we'll say this started inside the pleural cavity. All right, and then the black layer here, that's the visceral pleura, and then we have the pleural cavity right here. And so that can fill with all sorts of stuff. Maybe you pop a bleb. People with asthmatics, sometimes they rupture their alveoli, and air pours in to the pleural cavity, and you can get so much air in here that it actually compresses the lung tissue. You could get an infection in here, and the pus could build up. Right? And it can push in the lung. Anytime the lung pushes in, that's called an atelectasis. Then you can get a tumor, or you could get a lymph node on the outside pushing in the lung. So these are all causes of atelectasis. Specifically, these are called compression atelectasis. Compression atelectasis. And so pleural effusion, hemothorax, pneumothorax, where air gets in there, hemothorax, where blood gets in there, pyothorax, where pus gets in there. Any one of those overfilling of the pleural cavity can cause an atelectasis, but so can a tumor, so can a lymph node that's swollen up. Then we have another type, so this is the reabsorptive, aka obstructive atelectasis, and this is what I just said. If you get a complete beaver dam from a glob of mucus here, all of this tissue downstream, it won't die because this is not blood, but it'll collapse. This whole thing will collapse in because it'll have no more oxygen in it, and it'll have no CO2. No gas exchange can occur. So it can collapse the entire lung or the entire part that's affected. You get a mucus plug here, you're going to lose your whole lung. The whole lung is going to collapse in. So the further out the beaver dam is, the less of atelectasis will occur. See how that works? All right, so everything I just said. So reabsorptive atelectasis, something beaver dams, completely blocks one of the airways, usually one of the small airways. And everything I just said, the air gets sucked out and it can't get replaced, so it collapses. And yeah, mucus plugs are notorious for doing this, and people with chronic asthma or chronic bronchitis as well can do this because there's a lot of mucus around, and those are absorption atelectasis, aka obstructive atelectasis. Here's a 55-year-old patient with chest pain and dyspnea comes in. You take a chest x-ray. What do you think of this? Well, let's see, what do we think of this? So I always check the costophrenic angles first. They look good. Check the hemidiaphragm. Something's wrong. What's wrong there? That's up too high, right? The right hemidiaphragm. So there's a sucking force. Something's sucking up that hemidiaphragm. And then we look at the left upper lobe, no problem. What's going on with the right upper lobe? It's all shrunken. So the entire right upper lobe is sucked in because of a big beaver dam in the lobar bronchus or bronchi. Right. That's a patient with chronic bronchitis, and yeah, that can happen. The superior lobar bronchus completely blocked, and that's what you get. So that is a reabsorptive atelectasis, and it sucked up the hemidiaphragm. It can also suck the trachea sometimes over toward it. It can suck the mediastinum toward it if it's bad enough. What's some fun facts or not so fun facts about COPD? It's the third leading cause of death. It's the second leading cause of morbidity behind heart disease, but it's the third leading cause of morbidity or of death, only behind heart disease again and behind cancer. Population prevalence is 6.4% of COPD. That's a huge number. This is not like Marfan syndrome. It really likes white people. 80% of people who get severe COPD are white people. So it really picks on them. Smoking, if you're a heavy smoker, almost half of you are going to get COPD. It's not everybody who smokes gets it, but it's a huge risk factor for COPD. If your mother and father or grandparents, if anybody who has died of COPD or has COPD is severely disabled, you are absolutely insane if you smoke cigarettes or even around cigarettes. You're already going down the road towards COPD, and to smoke cigarettes, you probably got a 70% chance or 80% chance of getting it. So that's just insane. There are two classic ways to classify this disease. I don't like them. The medical texts don't acknowledge them anymore, but Robbins and Rubens still use them, and that's what chiropractors use. So I have to cover them. They are COPD type A and COPD type B. And originally they were thought COPD type A was not too bad. You weren't going to die from that. And COPD type B was very, very bad. You're going to die from this. And it's ridiculous. Type A, we'll learn, is chronic emphysema, and people die all the time from chronic emphysema. Type B is chronic bronchitis, and they die from that as well. But some people don't. I mean, it's silly to put these two. But shame, yeah. I mean, come on, Rubens and Robbins, let's get up to speed here. Way back in 13, Weinberg, which is a pulmonary medicine book I absolutely love, 6th edition. 2013, way back in 2013, they got rid of this classification, the pink puffer and the blue bloater. But nevertheless, I have to teach you because it's on boards. So the pink puffer is COPD type A pink puffer. Sometimes it's called predominant emphysema. And these patients have emphysema. How do you remember that? Type A stands for emphysema. Type B is easier, bronchitis. A is emphysema. Emphysema, what is emphysema? We don't completely understand it, the pathophysiology of it, but it is a chronic inflammatory disease that gets out of control. And it's weird because it only affects the respiratory unit to varying degrees. There's 4 or 5 different types. Rubens and Robbins only talk about 2 types. By far the most common is one called, and you know what, before I go on, I assume you remember the respiratory unit, right? We've talked about it. Here's an easy view of it. So we have, well, you can't see the terminal bronchiole. So here's the terminal bronchiole. That's it. That's the end of the conducting airway. And then the terminal bronchiole splits into bigger or smaller bronchioles, which are called respiratory bronchioles. Histologically, you can always tell respiratory bronchioles because they have alveoli coming off them. All right, alveoli just don't always end at the end. So this is part of the Asana, or aka respiratory unit. And then the respiratory bronchioles split into smaller units called alveolar ducts. So here's alveolar ducts. They have even more alveoli on them. And at the ends of the respiratory ducts, you have tons of it's like a little grape cluster. And those are the alveoli. And the whole cluster is called the alveolar sac. All right. So now with that little anatomy refreshed, there are several different types. We're going to worry about 2 of them. There is, and I took most of the slides out here as well. We're just going to give you the facts on this. There's Centra acinar emphysema. This one, the inflammation only occurs, well, mainly occurs in the respiratory bronchiole. And it stays there. So the alveoli are spared in this one. You can still have all sorts of trouble. You can have some collateral inflammation, but it's not as bad as one called pan-acinar emphysema. And remember, the respiratory unit, an AKA for that respiratory unit, is the asinus. So pan-asinar means, pan means everything. We've talked about that. And which one? COP or, let's see, I'm switching gears here. Which one is a pan-inflammation? Crohn's disease or ulcerative colitis? Crohn's disease is a full thickness, a pan-inflammatory disease of the intestinal wall. So a pan-asinar emphysema, the entire respiratory unit is destroyed. This one is fatal. It's more rare, so usually it's not as bad. The most common one is the Centra asinar. And here's the example of it. So Centra asinar, here's the again, we don't see the terminal respiratory bronchiole here, but it would be splitting into respiratory, or I'm sorry, we don't see the terminal bronchiole, but it splits into respiratory bronchioles, which we see. And then we have alveolar ducts, which are here and here. The alveolar ducts are just filled with alveoli. And I mean, this isn't a very good drawing, is it? This is a better drawing. So we can see the respiratory bronchioles here. They have more alveoli, but they have alveolar sacs in the end. So this is really a terrible drawing. But the Centra asinar, you can see that the inflammation has destroyed the connective tissue between alveoli and weakened the wall. It's so weak that it can't take oxygen. Oxygen just blows it way out because the wall is so weak and damaged. So you get expansion of the proximal part of this asinus, right? The pan-asinar emphysema, that affect, and this is not a great drawing either, it affects the entire alveolar duct, the alveolus, and it affects the bronchiole, the respiratory bronchiole as well. All right, and while I'm here, let me explain this, so I don't have to explain it again because this is a good picture. So how does emphysema cause overinflation of the lungs? Well, it destroys all these septums right here between the alveoli. So all of these are gone. So, and then it weakens the walls of the bronchi and the alveoli. So when you get air, CO2, and oxygen in here, this thing just blows up like crazy because it's so weak. And you get all this, and then you can't transfer the air out or transfer the CO2 in very good because it's just dead airspace. And that's what gives us an overinflated lung. All right, back to COPD type A. So the age range is about, they're a little bit older usually than COPD-B patients, so the average onset is about 63. They have shortness of breath. Typically has been getting worse over the past 3 or 4 years. They finally come into the doc and he sends them to a pulmonologist. They're smokers, so they're puffers. I mean the bronchitis patients, they're both smokers. But they're pink. Where does the pink come from? The pink comes from the fact that their blood is usually oxygenated. They don't, I mean, at least in the early stage in this classic teaching, they're not cyanotic yet, so they're not near death. Therefore, all the blood gases will be normal. That's where the pink puffer comes from. And then the barrel chest here is because they do get the asinar unit, or the, I don't know, I'm having trouble remembering that also, the asinus, or the respiratory unit. The respiratory unit blows out, and it can, as I just drew, and it can cause a barrel chest. Right? The cough, as I already said, it's typically not there all the time. It may even not be that, maybe just in the morning. That's not too bad of a problem. Unlike people with chronic bronchitis, these patients don't typically develop cor pulmonale as much either. They can in the later stages. And remember, this is classic teachings here. Diaphragmatic excursion will definitely be decreased if the lung tissue is starting to kind of coalesce together and you're getting dead air spaces. They're typically not cyanotic, so they have normal gases. They don't have acidosis. The body morphologies are typically skinny. That's called asthenic. They have an asthenic build. And they may develop a barrel chest later in the disease, as we said. Breath sounds are typically quiet on auscultation. In advanced type A, that's when things go off the wheels. You can have lung overinflation, low hemidiaphragms, and narrow mediastinum because half of their lung is just dead airspace and it doesn't work and it's overinflated and it blows your chest. It's very uncomfortable. And the treatment, I took all that out, but the treatment for this is you can actually have a surgery to remove all the dead tissue and take a quarter of your lung out, and it actually makes them feel a lot better and the chest goes back to normal. They may have accessory muscle breathing and pursed lips, kind of the monkey kiss breathing, which helps with the pressure inside the tracheobronchial tree. You can look at that. I'm not going to test you on that. I might ask the word though. So here's a normal lung. Look at the hemidiaphragms are normal. How come this right one is up a little higher? While I take some water here. Tell me. Good, I heard some of you say it. The liver. The liver pushes this up. Yeah, but we can see nice lung tissue everywhere. Great. How about this guy? 72-year-old comes in, complains of exertional dyspnea, just can't go up the stairs anymore. What's the diagnosis? Well, this is crazy looking. Look at the hemidiaphragms. They're pushed way down. Mediastinum is squished. I mean, the photons are ripping right through the lung here. There's nothing to stop it. So this is all dead lung tissue. This needs to be cut out. So, yeah, that's no good. It's chronic emphysema. Right? Or emphysema, A for emphysema type, or you could say COPD type A. All right, now type B, these are the blue bloaters. So again, traditionally, where the B goes with bronchitis, chronic bronchitis. What is chronic bronchitis? It is an overreactive or a chronic overactive inflammation that targets the respiratory unit of the tracheobronchial tree, and the tracheobronchial tree. It targets everything. That should be "and" there on slide 50, and the bronchial tree. Remember, emphysema targets the Asana unit or the respiratory unit. This one targets everything, and it's a chronic inflammation. And goblet cells also are very overproductive in this condition, so you have way too much mucus going on. Then the question is, okay, it's a chronic inflammation. What is it? Is it autoimmune related? We don't really know for sure what it is, but we know things that stimulate the inflammation. Cigarette smoke is notorious, the most common cause of this, whether you smoke or your neighbor smokes or you're just exposed to it. Your significant other smokes. The smoke gets in your tracheobronchial tree and your respiratory unit, and it causes an inflammation, and it stimulates goblet cells. When they get inflamed, they overproduce mucus, so you get all clogged up with mucus, and you get repeated infections can do this. Pollution can do this. The male is typically a little bit younger onset, 43 years of age. These patients are also smokers. They're actually really heavy smokers usually. And these people, unlike type A, they have a chronic productive cough. And productive means there's nasty green stuff coming out. And yeah, why do they have a chronic cough? Well, first of all, the smoke or pollution or whatever it was, what the cause of the chronic inflammation has also caused epithelial metaplasia in the tracheobronchial tree. And it's basically destroyed the mucus escalator. We've talked about that before. Remember, normally the tracheobronchial tree is lined by ciliated pseudostratified columnar epithelium, and the inflammation, it gets inflamed too easy, and the body says, forget this, we need to stop this inflammation, so it puts in a new type of tissue, non-ciliated stratified squamous, which can tolerate the smoke better, but you don't have a mucus escalator. So how are you going to get that overnight mucus and all the dirt and bugs and debris that you sucked in all day, how's that going to be cleared out? Well, it's not. You have to physically cough it out, and that's why these people are, especially in the morning, it's just they're coughing and coughing and coughing. And we said the goblet cells don't contribute. Some research shows that the goblet cells might even be the start of this whole thing from overproduction. All right, so bacterial infections and pneumonias are really common because if your mucus escalator system is broken, you can't clear out the bugs, and they can burrow into the walls and get into the parenchyma of the lungs and start an infection. The cough is associated with expectoration. That's just coughing up of nasty stuff, green, foul-smelling phlegm, which comes out of the tracheobronchial tree. Typically, the history is that this coughing up of nasty stuff, this expectoration, is beginning worse. Usually started off one winter, a few months, and then it's 3 months of the winter and 4 months of the winter. Once it goes a couple years in a row, you can have the diagnosis of chronic bronchitis, and pretty soon it goes year-round. And yeah, and these people have coughing attacks in the morning, just to clear all that stuff out. Exertional dyspnea will start to become a problem because from chronic infection after infection after infection, you're wrecking the tracheobronchial tree, scarring up the airway, so there's not much. The lumen of the airway is decreasing, so it's harder and harder to get oxygen into your blood. These patients are usually really heavy smokers. More than 20 pack years is typical for these patients. And chronic inflammation, we said that it can also scar up, because remember I said this affects the tracheobronchial tree and the asana, so it can scar up the microcirculation as well. And therefore, if you scar up the microcirculation, it's hard for the right heart to push blood through the microcirculation. And there you wreck your right heart. And so this is probably the most common cause of cor pulmonale. Remember, cor pulmonale is blowing up and failure of the right heart from a lung condition, not from left heart failure. It definitely causes pulmonary hypertension, and it wrecks the right side of your heart. It becomes hypertrophic, and then it's so big the muscle just stops working, and then they have a big flabby dilated right heart and it doesn't work, and that's cor pulmonale. What about the radiographic appearances of chronic bronchitis or COPD type B? Well, the hypertension or the pulmonary hypertension will blow up that right ventricle. So you get right ventricular hypertrophy, you'll get right atrial hypertrophy. What's that going to do to the axis of the heart? The axis is pushed way to the right. So if I showed you an EKG, you should be able to pick that out way past 90 degrees, maybe 120 degrees. The lung fields will be congested from the increased pressure around the microcirculation. You can get congestion in the lung fields, or they can be clapping down from the chronic inflammation and scarring up, which will make it harder for the photons to get through and make it more radio-opaque on X-ray. Right, so here's somebody with pulmonary hypertension and congestion of the lung fields. And yeah, this is normal lung tissue up here, but that's about it. This is way too thick. And the heart looks crazy. It's rolled over, so the right ventricle has rolled over kind of counterclockwise from a S to I view. And we have the right ventricle here. The right atrium is huge. And yeah, that's no good. Now the blue bloater, blue means that these patients are cyanotic. And I mean, they can get blue in type A as well, but this is the classic description. This is what's on boards. So they're cyanotic later in the process, and we already talked about why that is. But the blood gases will be messed up. If your microcirculation around your respiratory unit is messed up, you can't exchange gas. And if it's scarred up, if the alveoli is scarred up, you can't exchange gas well. Therefore, you're going to have increased levels of CO2 in your blood, right? You can't blow it off. So you have, what's that called? Hypercapnia. Hypercapnia. If you can't clear your CO2 from the blood, you can't clear your hydrogen ion from your blood. Remember your basic physiology. Blowing off CO2, creating CO2 sucks up hydrogen ion from the red blood cell and from the blood serum itself. And so you're going to develop respiratory acidosis from this as the CO2 builds up. Examination findings, because of the edema and the fluid starting to, pulmonary hypertension is going to cause blood fluid to start leaking into the alveoli, and you're going to hear crackles might be present. Diaphragmatic excursion is typically normal. Diaphragmatic excursion is decreased in patients with emphysema. Remember this physiology. I won't go through this. You guys know this, right? But bicarbonate can this is a red blood cell here. Bicarbonate can, most of it is transported on the red blood cell, and that's how CO2 is, right? There's a little CO2 in the plasma, but most of CO2 is transported as bicarbonate ion. When it's time to exchange gases, the bicarbonate combines with a hydrogen ion. It soaks up a hydrogen ion, whether you're in the red blood cell or whether you're out in the plasma here. It sucks up a red blood cell, makes carbonic acid, which is not shown here. The carbonic acid dissociates into CO2 and water. So you basically are taking that hydrogen ion and turning it into water. And that's how you get rid of the hydrogen ion. So if this is all scarred up, it's all scarred up with scar tissue from infections and the disease process, CO2 can't get out. Well, there's no reason to form it. So you keep this in the blood, and that's acid that will decrease the pH of the blood and give you respiratory acidosis. You guys know that, right? If you don't know that, somebody email me that. I go over that fast. I assume you know that from your pulmonary physiology. All right, let's get into asthma. Asthma is characterized by sporadic attacks of the bronchial tree. So it's spasm of the smooth muscle, usually in the terminal bronchioles are the most affected. I mean, even the respiratory bronchioles have a little bit of smooth muscle, and all the bronchioles have some smooth muscle. Terminal bronchioles are affected the most, though, because they have pound for pound. They're like the arterioles. They have more muscle than any other blood vessel. So terminal bronchioles are kind of the same. If you spasm that muscle, you're going to close off the pipes. You can't get CO2 out. You can't get oxygen into the blood, and you're in big trouble. And the person can die of hypoxia. So here's a terminal bronchiole, a normal one. There's a nice big lumen. Oxygen is coming in or going out of here. CO2 is going in to be cleared. This patient's having an asthma attack, and look at the smooth muscle is like 5 times bigger, and there's hardly any lumen left. And on top of that, during the asthma attack, the goblet cells are stimulated to way over-secrete mucus. And if this is chronic bronchitis, it's a similar type of story. Chronic bronchitis, you typically don't have the smooth muscle spasm, though. That's the difference between those two. It is the most common chronic childhood disease in developed nations, period. 8% of children and 8% of adults are affected by this. That's 25 million Americans. There is no cure for asthma. African Americans are affected more by asthma than white people and other races, so they get picked on with regard to chronic asthma. Its occurrence is genetic and environmental combination. About 50% is thought to be to faulty genes, and there's a whole bunch of genes. We're not going to go down that rabbit hole. 50% is thought to be to the environment. And the genes, one of the big problems with genes is they cause a hyperreactive airway. And so almost all asthmatics have a hyperreactive or hyperresponsive airway. What does that mean? It means that you get one little allergen in there, and the smooth muscle goes crazy and causes a spasm, and you get a vasoconstriction, not a vasoconstriction, but you get a constriction, a bronchial spasm, a bronchial constriction of the tube, when normally you should be able to tolerate a few allergens. So you're overreactive to this thing, and your goblet cells are also overreactive to this. Asthmatics typically have really large submucosal glands, which are the ones that sometimes they're just called mucus glands, but they're really submucosal glands that live in the walls of the bronchial tubes. And we said that's one of the causes, one of the problems with asthma is those glands are so used to working. It's just like lifting weights. They get bigger and bigger and bigger, and as they get bigger, they make the lumen narrower, more narrower. And yeah, so that's the problem. And plus they're bigger, they're really good at secreting mucus, so they over-secrete mucus. Okay, some more basic stuff you probably know. During an attack, asthmatics overproduce IgE, immunoglobulin E. Of course, recall that IgE is an antibody, which is involved in seen in allergic reactions. And IgE triggers the release of epithelial cells to release histamine, which is going to make the microcirculation really leaky. And so it sparks an inflammation process, and it lets blood fluid leak out really easily in the microcirculation. In severe cases, the airways may become completely plugged. Yep, we looked at an example. What was that called? It's called a reabsorption atelectasis. Very frightening, very painful condition. What are the risk factors of asthma or developing chronic asthma? Well, family history, genetics is a big one. Especially if family history for atopy. What's atopy? Atopy means you're allergic to everything. You have atopic dermatitis, or you did when you were a child. You have spring fever, fall fever, hay fever. So what does that mean? That means your eyes get red. That's conjunctivitis. You get rhinitis. Your nose is running. Food allergies. So peanut allergies. You're just atopic. Then another strong risk factor is exposure to tobacco smoke. So prenatal, so like this picture, this horrible human smoking while she's pregnant. I mean, everybody should know that. There's no excuse. It's just selfishness. My opinion, I don't put my opinions in much, but yeah, that's not good. Because it increases the risk for that child suffering a lifelong battle with asthma. And yep, severe pollution could do the same thing. And she's at risk for the development of asthma with the passage of time for smoking as well. So it affects your unborn and it affects you. It increases the risk for asthma. There's a whole bunch of genes. I took all those slides out. I just want you to know 3 of them though. You can get tested for these. There's the DDP10, the GRAPA-A, and the Sphinx5. Gene mutations in these all increase the risk, make the airway hyperresponsive, make the goblet cells overproduce mucus. So mutations in those genes are trouble. Immediate family history, we talked about that. Children who've had viral pneumonia are also at risk for getting asthma later on down the road. There's 2 basic types of asthma. There's allergic asthma and non-allergic asthma. Sometimes they're called atopic for allergic and non-atopic for non-allergic. So non-atopic asthma, just like the word says, they have an asthma attack, full-blown asthma attack, but they've never been able to figure out a trigger for the asthma. It's not cigarette smoke, doesn't seem to be. It's not going to a polluted city. It's not cat fur. They don't know what it is. It just happens. And even more confusingly, they're usually not atopic. They don't have any allergies, and their parents don't have allergies. So this can be a really mysterious one. Then there's atopic asthma, where there's a known trigger of some kind. This is by far the most common type. These patients, almost half of them, well, 40% of them have atopy. So if you have atopy, this is the type you're going to have. There's all kinds of triggers, pollen, animal hair, other fur from other animals, dogs, ferrets, you name it, dust mites, smoke, of course, cigarette smoke. The list goes on and on. There's other types of asthma too, which we just don't have time to get into. You could further, like non-atrophic asthma, you could subdivide that. Sometimes exercise can stimulate an asthma attack. Strong emotions can stimulate an asthma attack. Cold air can stimulate an asthma attack. Those are non-atopic types of asthma. We don't understand the mechanism behind those. And then there's the atopic type subcategories: tobacco, occupation, dusts in our area, silicon. Silicon dust is notorious for sparking these. Drug-induced, air pollution-induced. We know the cause of these things. What are the classic symptoms of an asthma attack? One word should come to mind: wheezing. We talked about that in lab, wheezing. You can't blow air out. You're going to be coughing because the mucus, the goblet cells during an attack are going to be overproducing mucus, so you're choking on the mucus. I mean, you can't exercise. You go upstairs and you're out of breath because your lungs aren't working. Your lungs aren't providing oxygen for the blood, so you start getting a little cyanotic. During an asthma attack, you definitely want to be seated, so gravity is helping push the mucus down to one area of the lungs, down to the bottom of the lungs, so the upper airways and upper part of the lungs are still working. So that's called orthopnea. Very severe difficulty breathing, which would spread out the mucus and take out more lung tissue. Patients will be sitting or standing for sure. Anxiety, of course. Think you're going to die, and you might die. Anxiety for good reason. Accessory muscles may be kicked in as you're fighting for air. Oscillatory sounds, as we talked about in lab, you're going to have a wheezing sound. That's a 440 hertz pitch. It's a musical note sounding thing. Sounding oscillatory sound, which we can hear over the lung field, so wheezes. Chest radiograph may be normal unless you have chronic asthma and you've already caused damage and the microcirculation is scarred up. A patient, in chronic asthma, you can scar up the microcirculation. You can develop cor pulmonale with this in the long term. And remember, cor pulmonale, if you have cor pulmonale, you have pulsus paradoxus. See how this is all tying together? So it's possible for asthmatics to have pulsus paradoxus. That's going to be someone who's battled it in their probably 50s, 60s, battled it for a long time. The treatments, I took a lot of slides out. You'll be happy. I just want you to know there are bronchodilator drugs that can open up the airway and help you breathe. And let's look at this a little more closely. So there's two flavors of these bronchodilator drugs that you can use, and you can use both of them at the same time. So there's the beta-2 agonists. So remember, an agonist, is that going to stimulate a response or block a response? Agony is going to make that thing work, so it stimulates a response. So these drugs bind and activate beta-2 receptors, which live on the smooth muscle of the tracheobronchial tree, and it causes them to vasodilate. It causes the smooth muscle to relax. I took out all the slides about calcium and everything. We'll just get to the facts here. And it causes them to relax, and you can breathe again. Classic example, I do want you to know albuterol. It's so common. That is a beta-2 agonist drug, and that relaxes by relaxing, or works by relaxing the smooth muscle. The other flavor of drugs is cortical steroids, like mometasone is a classic example of this, and its job is to snuff out the inflammation that can get brewing inside the bronchial wall. And that because that chronic inflammation that goes with every attack of asthma will slowly scar up the small airways and decrease the size of the lumen. And so, yeah, so you might, if it's bad enough, I took these slides out, but the rule is if you have to use the beta-2 agonists more than twice a week, then you should add in inhaled cortical steroids as well. That's kind of the rule of thumb. So you could be on both of these drugs. And yeah, and what it also, as a side bonus, it enhances beta-2 receptors. And so it makes the beta-2 agonists work more effectively. So it can help them as well. Plus it snuffs out inflammation. Now, what are the dangers of cortical steroids? I think we've talked about this, but I'm not sure, but we better talk about it. Cortical steroids in children, it can stunt their growth, close growth plates early. It can decrease bone density and cause osteoporosis. It can cause thinning of the skin. It can cause cataracts. It could cause Cushing's syndrome if you're on a high enough dose of it, although that's usually seen more with the oral steroids like prednisone. And then if you're on a set dose of glucocorticoids, maybe it shut off your HP axis and a major stressor occurs and you can't make any more cortisol because you're on a fixed dose. Your HP axis is shut off. So you could have an attack of adrenal insufficiency or adrenal crisis, possibly with this. Or when you're coming off, you could go into adrenal insufficiency because it might take a while to wake up your HP axis again. All right, I used to play that in class, but you can watch it on your own. This is just a horrible, scary thing with a child having a severe asthma attack. Heartless doctor. You should check out her bedside manners. Just absolutely terrible. I'll let you see that for yourself. All right, thanks for watching. Sorry I couldn't be there giving these lectures in person, but at least next quarter things look like they're going to be back to normal. Knock on wood. All right, see you later.